To continue about our lecture today about the liver and biliary system, and talking about the investigation of a patient with liver disease. Reaching to this point, the imaging techniques is very useful, is very important in diagnosing patients with liver disease, and mainly the ultrasound here is very useful. The ultrasound, you can determine the site and general nature of any structural lesion in the liver, is very helpful. And you can identify, for example, a gallstone when there is obstructive jaundice, mass or tumors, or even thrombosis in the hepatic vasculature. CT scan is very important. You can send the patient for CT scan for detection of smaller focal lesion in the liver. MRI of the liver is very helpful, and MRCP and ERCP, endoscopic retrograde cholangiopancreatography, أيضا very important to know the localized and to confirm the etiology of focal liver lesion, particularly primary or secondary tumor. أيضا you can do PTC, percutaneous transhepatic cholangiography, or PTC-D drain, and T-tube cholangiogram. T-tube cholangiogram, important test used commonly in patients post-operative after biliary surgery to assess the patency of the biliary passages. This is a CT scan of a patient with liver cirrhosis. As you could see here, the outline, irregular outline of the liver with shrinkage in the size of the liver. This is ascites, this is ascitic fluid, and this is the liver with irregular outline, and this is enlargement of the spleen, enlarged spleen, in the liver cirrhosis or liver disease, for example. Liver cirrhosis, splenomegaly with portal hypertension. This is the stomach, and this is the collateral circulation, collateral vessels. This is ERCP, endoscopic retrograde cholangiopancreatography. طبعا هاي endoscopy راح ندخل هنا reaching in the second part of the duodenum، نوقف قبال الأمبولة of Vater، نطلع نسوي cannulation. You can inject a dye showing the CPD, the common bile duct. Here is very nice, very normal, and this is the pancreatic duct. هاي هي pancreatic duct، أيضا very nice and normal. And this is the biliary passages, the biliary patches, the common hepatic, the left and the right hepatic duct. This is MRCP showing biliary structure. This is the MRCP here. This is dilatation of the CPD and the intrahepatic biliary passages, and this is a structure here, possible cholangiocarcinoma in the distal common bile duct. طبعا راح نشوف هنا ال pancreatic duct, very nice, unaffected, normal looking pancreatic duct, and this is the dye reaching the duodenum. Important test even during investigation of a patient with liver disease is the viral markers. As you know that hepatitis is one of the commonest cause of liver disease, and viral hepatitis is the commonest cause of hepatitis. And to know what type of virus involved in the liver, you have to send the patient for viral study or viral markers. So you can send the patient for HIV have antibody, hepatitis A virus antibody. You can send for HBS antigen. HBS antibody أيضا useful during vaccination, for example, of the liver. You can send the patient for hepatitis D antibody, HCV antibody, hepatitis type C. Nowadays very important, very commonly we see patients, especially after post-transfusion hepatitis. Hepatitis type E أيضا HEV antibody, you can send it. You can send for other viral viruses like CMV and EBV virus, cytomegalovirus and Epstein-Barr virus, and herpes simplex virus and yellow fever viruses. Finally, important test in investigation of a patient with liver disease is liver biopsy. So you can do a liver biopsy under ultrasound guide to confirm the severity of liver damage and to provide etiological information حتى نعرف السبب. It's performed percutaneously طبعا with TrueCut، نسميها منجيني needle موجودة، منجيني needle، نسوي الليفر بايبسي. بس هنا نحتاج cooperative patients، ولازم نسوي له assessment before doing the procedures، لأنه هذول دائما عندهم يعني impairment بالprothrombin time، ف should be less than 4 seconds prolonged, not more. إذا more لازم نعطيهم fresh frozen plasma أو نعطيهم platelet مرات. Transfusion before the procedure because of the risk of bleeding. أيضا platelet count should be more than 80 by 10 to the power of 9. فإذا عندنا ثرومبوسايتوبينيا أيضا يعني احنا مثل ما قلنا ذول الليفر ديزيز فنتوقع نشوف عندهم ثرومبوسايتوبينيا نتوقع البي تي prolonged فإذا البي تي less than 4 okay you can do it. If it is more no you have to give مثلا fresh frozen plasma. If the platelet count is more than 80 it's okay you can do it. But if less, no, you have to give a platelet transfusion before the procedure because of the risk, because of the complication of liver biopsy. You know, we have many important complications of liver biopsy. Like, for example, he could have a pain in the shoulder area or the abdominal pain. He could have bleeding, and he could have biliary peritonitis, especially when there is طبعا biliary obstruction. فأيضا you have to exclude biliary obstruction before doing the procedures. You have to exclude مثلا massive ascites أيضا before doing the procedures if the patient have severe and advanced COPD or severe anemia. It's not advisable to do a liver biopsy. طبعا histologically يعني generally speaking histologically of liver biopsy الليفر هو لو راح يطلع عندنا اذا diseased liver لو يطلع عندنا fatty liver اللي نسميه steatosis لو يطلع عندنا hepatitis يعني inflammation you have to know the grading of inflammation لو نشوف cirrhosis اذا هو لو fatty liver steatosis لو hepatitis لازم نشوف inflammation and grading لو cirrhosis ايضا لازم نشوف ايضا fibrosis and the stages of fibrosis of the liver. Now, after we finish the investigation of a patient with liver disease, we have to talk about the common presenting features of liver disease. What are the main presenting features of liver disease? Mainly هو jaundice. وإحنا خدناها previously jaundice. Jaundice is a yellow discoloration of the skin and sclera due to elevated total serum bilirubin. طبعا يكون detectable clinically. You can detect it clinically by looking to the sclera of the patient, especially on daylight. If it is more than 2.5 or 3 milligram per deciliter, you can detect it clinically. طبعا you have three types of jaundice. We have the prehepatic اللي هو hemolytic jaundice, prehepatic, hepatic or posthepatic jaundice. This is a discoloration of yellow discoloration of sclera in a patient with deep jaundice. Now, number one is the prehepatic jaundice. It's caused by hemolysis, فنسميه hemolytic jaundice, or by congenital hyperbilirubinemia. It is characterized by isolated raised bilirubin. طبعا راح يصير عندنا بس ال TSP elevated and mainly indirect, unconjugated. طبعا jaundice due to hemolysis is usually mild. فإذا mild jaundice or mainly indirect because a healthy liver can excrete bilirubin load 6 times greater than normal before unconjugated bilirubin accumulates in the plasma. The most common forms of non-hemolytic طبعا هو Gilbert syndrome. The most common form of non-hemolytic hyperbilirubinemia is Gilbert syndrome. فهذول دائما يجونا jaundice. الجوندس usually mild jaundice with normal other liver function test. It is an inherited disorders of bilirubin metabolism. The second important types of jaundice is hepatocellular jaundice. اللي هو common types of jaundice هو hepatocellular, and the commonest cause of hepatocellular هو hepatitis. Hepatocellular jaundice results from an inability of the liver to transport bilirubin into the bile. طبعا هنا راح both the conjugated وال unconjugated تصعد عندنا due to swelling of the cells and edema resulting from the disease itself may cause obstruction of the biliary canaliculi. لذلك راح نشوف element of obstructive and element of hemolytic. يعني المهم راح نشوف direct and indirect bilirubin both are elevated. وياها شنو elevated بالliver enzymes. فإذا high liver enzymes with high total serum bilirubin. This is mainly occur in hepatitis. والhepatitis ممكن أن يكون viral hepatitis, for example hepatitis A or B, or ممكن drug induced hepatitis or hepatitis ischemia. وهنا طبعا liver biopsy has an important role in defining the etiology of hepatocellular jaundice and the extent of liver injury. The third important cause of jaundice is the obstructive jaundice or cholestatic jaundice, which may be caused by failure of hepatocyte to initiate bile flow, or obstruction of the bile duct or portal tracts, or obstruction of the bile flow in the extrahepatic bile duct between the porta hepatis and the papilla ovata. فإذا in the absence of treatment طبعا cholestatic jaundice tend to become progressively increased, more severe, because conjugated bilirubin is unable to enter the bile canaliculi and passes back into the blood, and also because there is a failure of clearance of unconjugated bilirubin arriving at the liver cells. إذن بالobstructive jaundice راح يصير عندنا elevated high total serum bilirubin and mainly direct. فإذا direct hyperbilirubinemia with elevation of the liver enzymes, بس ما تصعد هواية مثل بالهيباتيتس. The cause of cholestatic jaundice may result from defects at more than one of these levels. فممكن يكون intrahepatic, ممكن يكون extrahepatic, for example stone or stricture or tumor. طبعا you have features of cholestatic jaundice. For example, he will have pale stool, he will have dark urine, يعني clay colored stool, and deep color urine, and he will have itching or pruritus. You will have malabsorption of vitamin A, D, and E and K because of the decrease in the bile salts and bile pigments. You may have weight loss and steatorrhea. He may have osteomalacia, bleeding tendency due to vitamin K deficiency. He may have lipid deposits, and when there is infection, for example, in patients with cholangitis, you may have fever, rigor, and pain if gallstone is present. And thank you.